Preoperative investigations. Routine preoperative investigations are only necessary if there are comorbidities or certain indications. Table 1. Suggested indications for specific investigations in the preoperative period test indications CBC. Major surgery requiring group and screen or cross and match. Chronic CV pulmonary, renal, or hepatic disease. Malignancy known or suspected anemia, bleeding diathesis, or myelosuppression. Patient 1Y/O. Sickle cell screen. Genetically predisposed patient, hemoglobin electrophoresis if screen is positive. Inner. Act. Anticoagulant therapy. Bleeding diathesis. Liver disease. Electrolytes and creatinine HDN. Renal disease DM. Pituitary or adrenal disease, vascular disease. Digoxin diuretic or other drug therapies affecting electrolytes. Testing glucose level DM repeat on day of surgery. Pregnancy SSHCG. Women of reproductive age at heart disease DM. Other risk factors for cardiac disease. Subarachnoid or intracranial hemorrhage, cerebrovascular accident. Head trauma CXR patients with new or worsening respiratory symptoms / signs guidelines to the practice of anesthesia revised edition 2013. Supplement to the Canadian Journal of Anesthesia, Vol 60, December 2013. Reproduced with permission copyright Canadian Anesthesiologists Society. American Society of Anesthesiology Classification. Common classification of physical status at the time of surgery. A gross predictor of overall outcome, not used as stratification for anesthetic risk mortality rates. ****, healthy, fit patient. ***2, a patient with mild systemic disease. E.g., controlled TWO-DM, controlled essential HDN, obesity smoker. ***3, patient with severe systemic disease that limits activities. G-stable CAD, COP, DM, obesity. ***4, a patient with incapacitating disease that is a constant threat to life. E.g., unstable CAD, renal failure, acute respiratory failure. ***5, moribund patient not expected to survive 24H without surgery. E.g., ruptured abdominal aortic aneurysm AAA head trauma with increased IPE. ***6, declared brain dead, a patient whose organs are being removed for donation purposes. For emergency operations, add the letter E after classification E. G is ***3E. Preoperative optimization. In general, prior to elective surgery, any fluid and / or electrolyte imbalance should be corrected. Extent of existing comorbidities should be understood. And these conditions should be optimized prior to surgery. Medications may need adjustment. Medications. Pay particular attention to cardiac and respiratory medications, opioids, and drugs with many side effects and interactions. Preoperative medications to consider. Prophylaxis. Risk of G reflux, antacids e.g. sodium citrate, H antagonists and / or prokinetic agents e.g. metoclopramide 30min1H prior to surgery. Risk of infective endocarditis, GI/GU interventions, antibiotics. Risk of adrenal suppression, steroid coverage anxiety. Consider benzodiazepines. COP, asthma, bronchodilators. Add risk factors, nitroglycerin, and B blockers. Preoperative medications to stop. Oral antihyperglycemics, Do not take on morning of surgery. Enzyme inhibitors AC and angiotensin receptor blockers ARB. Do not take on the day of surgery. Controversial. They increase the risk of hypotension post-induction, but have not been shown to increase mortality or adverse outcomes. Therefore, some people hold and some do not. Warfarin. Consider bridging with heparin. Antiplatelet agents e.g. clopidogrel, ZA inhibitor, direct thrombin inhibitors. Discuss perioperative use of ASA and NSAIDs with surgeon 1 patients, cardiologist/internist. In patients undergoing non-cardiac surgery, starting or continuing low-dose ASA in the perioperative period does not appear to protect against postoperative MI or death, but increases the risk of major bleeding. Note, this does not apply to patients with bare metal stents or drug-eluting coronary stents. Toronto Notes 2021. Classification of laryngeal view. Figure 3. Grade 1. All laryngeal structures revealed. Grade 2. Posterior laryngeal. 2. Posterior vocal folds. 2b. Arytenoids. Grade 3. Larynx concealed, only epiglottis. Grade 4. Neither glottis nor epiglottis. Integration of the Duke Activity Status Index into Preoperative Risk Evaluation. BRJ Annis 2020. Index DASI questionnaire could be integrated into preoperative risk assessment methods. Tested cohort analysis of the measurement of exercise tolerance. MET study to characterize association of preoperative DASI scores with postoperative deaths and complications. Analysis included 1,546 patients 40Y/0 at elevated cardiac risk that had inpatient non-cardiac surgery. Results were nonlinear, but threshold was found. Functional capacity better than a DASI score of 34 was associated with reduced odds of 30D death or MI, or 0.97 per 1 point increase above 34, 95% psi, 0.960. 99 and 1 or death or new disability, or 0.96 per 1 point increase above 34, 95% psi, 0.92, 0.99. Conclusion: a DASI score of 34 represents a threshold for identifying patients at risk for myocardial injury, MI moderate to severe complications, and new disability. Continuation versus discontinuation of antiplatelet therapy for bleeding and ischemic events in adults undergoing non-cardiac surgery. Cochrane DB Syst Rev 2018, CD 12584. Purpose: to compare the effect of continuation versus discontinuation of antiplatelet therapy on the occurrence of bleeding and ischemic events in adults undergoing non-cardiac surgery. Methods are CTS and Cochrane Central Register of Controlled Trials, Medline and EMBUS that compared adults taking single or dual antiplatelet therapy for at least 2 weeks, including patients with at least one cardiac risk factor. Included general, spinal, and regional anesthesia and excluded minor procedures involving only local anesthetic/sedation. Results: 5 trials, 666 adult patients. Continuation or discontinuation had no difference on mortality at 30D postoperative RR 1.21, 95% size 0.34, 4.27. Blood loss RR 1.37, 95% size 0.832. 26. Or ischemic events within 30D of surgery RR 0.67, 95% size 0.25, 1.77. Conclusions: moderate evidence supporting continuation or discontinuation of antiplatelet therapy makes no difference on bleeding requiring transfusion. Low evidence supporting no difference in mortality or ischemic events. Preoperative investigations. Routine preoperative investigations are only necessary if there are comorbidities or certain indications.